I'll let Melody introduce herself as well.
Hi, my name is Dr. Melody Hernandez, and I've been working for Nicklaus Children's for 8 years now. And I started in the NICU. I was a bedside NICU nurse, and I transitioned into this role 2 years ago. I also got my master's and my PhD in biomedical sciences, and recently graduated from medical school. But I'm still working as an RN, as a telehealth RN, and I'm the lead RN on this project.
So we're very excited to be here today. We just wanted to acknowledge that we're just representing the larger Baby Steps team. So this, as you can see, we have the School of Nursing from University of Miami and Nicklaus on the slide. And so we do have this program as a partnership between our two organizations and the Florida Blue Foundation grant, the Quality of Patient Care grant, which is 3 years and $300,000, which was really the seed money that allowed this program to start and be implemented. That grant application and process was a joint venture between our organizations. So at Nicklaus, we have Dr. Yui Matsuda, who is our other co-PI along with myself. And then of course, you've met Melody. And then on the Nicklaus side, we have Evelyn Terrell, who is our director for telehealth, Flortana, who is our previously, she was our clinical specialist in the NICU, and now she's over our nurse practitioners who do transition of care. And then Martha Gonzalez, who is our director in the NICU. And I just wanted to acknowledge some of the funding, additional funding that has made the program possible. So I'm sure you guys are somewhat familiar with Nicklaus, but we are located in Miami, Florida. We have a very diverse patient population. About 70% of our patient population is Spanish speaking. We have patients that come to us from across Florida, from the Caribbean, and Central and South America as well. And we have currently, I think, 309 beds, but that's about to be bumped up because we opened a new addition to our psych unit. One thing to note about our hospital is we are not a birth facility. So all of the babies that come to our NICU are transferred in from outside organizations. And so what that means is the majority of our patients are, critically ill. They have either an acute surgical need perhaps, or they have a very, intense illness that cannot be managed at an outside hospital. So we don't have kind of the traditional feeder and grower babies, or just kind of like the transient tachypnea babies. So it is a little bit of a different patient mix. And we have a level 4 NICU. And if you have any questions about the NICU, Melody can answer all of them. She's our NICU expert here. So I'm going to pass it over to you, Melody, just to talk about the Baby Steps program.
So the Baby Steps program, this is just a little overview of our inclusion, is any patient that is discharged to their home setting within the state of Florida. And we schedule their first visit within 48 hours, and we have on-demand calls within Monday to Fridays. And it's up to 2 weeks post-discharge that the service is available to the families, totally free of cost. It is due to the grant, it's completely complimentary. Also, it has to be a RN that is bilingual, as Dr. Sariq said, that most of our patients are actually Spanish speaking, and we try and speak to them in the language that they're most comfortable in. And so we go over a range of many topics, infant issues, such as newborn care, bathing, administering medication, back to sleep. And we also talk about chronic patients with trachs, G-tubes, ostomies, and we help them with whatever their needs are with DME, any sort of equipment. Next. And so this is me actually speaking with a parent in the hospital, explaining to them the process of us following up with them for up to 2 weeks. And what we do is we try to identify any issues that the parents may need, or any resources that they may need after getting discharged. Since it's the most critical time, the 2 weeks after they get discharged from home from the NICU is the most crucial time in which they need help with doctor's appointments. They also need to get their routine in order with their medications, with the feeding, with their sleep. And so we talk about a list of various things. And I also make sure to give them resources such as case management, social work, transportation if they need it, connect them with their outside providers so that they can establish that relationship. And they also know who to go to if there's an emergency, where to call, what prescriptions. They would ask whatever specialty they're working with, since a lot of our patients are very chronic long-term patients, and they have a list of specialists just so that they're able to keep up with all that information. And also one of the big portions for what we saw success was that we build a therapeutic relationship with the patients before they go home. So I'll meet them at the bedside in the hospital, and I'll explain to them the program. I'll explain to them they're allowed to enroll. It's completely complimentary. And then we pretty much build our relationship from there, and they'll know that I'll be their point person for up to 2 weeks after they get discharged. And also telehealth is shown to be cost effective and feasible. And that's the main portion for us. Is a lot of our patients are actually public Medicaid recipients. So it's important that they're actually able to receive service within 2 weeks, since there may be a lot of changes in insurance when they get home, and they're actually able to see a medical professional within that time frame. So here is the implementation of our program. So we hired a NICU nurse, a dedicated NICU nurse, because when we started this program, we used to have nurses that were filling in the slots, and we saw that our success was having a dedicated RN to this program. So it's a 0.5 FTE, and so that nurse does the calls with the patients. We also developed training documents for the NICU nurses. We have a team, a cohort of 8 nurses outside of me as the lead, and which they can fulfill the need if we have more patients that need to do their follow-ups. And also we identified any technology needs, such as laptop, PC, also a designated area in which we can have private calls and not violating any HIPAA regulations. And we created, our organization actually created a telehealth platform, which was called pediatric, it's pediatric telehealth. I forgot the name right now. So that was actually developed by Nicklaus Children's, and it's HIPAA compliant, and it was where we can send the patients a link. Now we're sending them a directed link that is attached to their EMR, and we can go over some of their medical records, such as the discharge papers, so that we can make sure that if they have any questions, then we can address it at that moment. Also, what we do is we hold bi-weekly meetings between all of our team members, just to see if there's any issues, or if there's anything that we can improve on, and also to tell us like the wins that we've had in the last 2 weeks and how the calls have gone. And we speak with our academic team also at UM to talk about their nursing simulations that they give to their students. We also developed a survey which the patients receive after the call. They receive it directly after their telehealth consultation, and it's a survey. We'll be going over some of those that data later on. Also, we track data as in their demographics. So the patient's age, their prematurity, what gestational age they were born at. We also track their location, so their zip code, their county. We track what type of insurance that they are receiving, if it's public insurance, private insurance, and we also keep track of their preferred language. And all of this we've been able to do retroactive data to do analysis on readmissions and ED visits, which we'll also be talking about later on. Here is a workflow of our baby steps. On the top is our pre-discharge workflow. As I was saying, we identify in every single week, we have complex care rounds twice a week with our 2 teams of our physicians, of our neonatologists. And we talk about the needs that these patients may have. So social work needs, if they have any issues with actually the parents, if they have educational issues in which we need to reinforce education. And we talk about any determinants that they might have into being successful after they get discharged. We determine if they're eligible for the program, if they're within the state of Florida, and if they're going to go straight to their home. And then at that point is when I go to the bedside, I introduce them to the service. I show them how we would do like a mock call to make sure that they wouldn't have any technological barriers once they get home. Also, I give them the information. So if they needed any on-demand service, I give them my cell phone, give them my desk phone, everything, and how they can get onto the application. And then we have our call, and we document all that information on our SharePoint, in which that's some of the information that we've been able to retroactively look at to see what are the needs that the patients may have, what we haven't been able to assess or address. Also on the bottom is actually the telehealth call. So we have them, I will call the patient, see if they're available, if it's a good time. If not, I'll set a later time. But if they're available, I'll send them the link. And then we have our encounter. It's usually about 30 minutes. It depends on the severity of the case. What I like to do also before our 2 weeks end is have another consultation with them just to make sure that they know any reasons to go to the ER, how to reach out to their doctors, and pretty much just to wrap it all up and make sure that they feel comfortable going on their own. And this is some of the data that we've collected. In the first 3 years of Baby Steps, we were able to enroll over 670 infants and families. And we've had a total of 696 encounters. 53% has been telehealth. The other has been phone calls, and that's been due to connectivity. Also, telehealth it's still newer for some people. So a lot of it has to do with comfort, and, everybody wants to be picture perfect. So sometimes I just have to work with the parents on the verbiage that I use to explain to them why it's important that we're actually able to see the patient and address any needs at the moment. And in our post surveys, we've had 99.2% satisfied or highly satisfied, which we'll go over that later. And the infants enrolled in the program experienced a decrease in urgent care and ER use. It's 10.7 of our patients that are enrolled in Baby Steps, and it's 18.9 of the patients that are not enrolled that actually go to the ER within 30 days. So that's showing about 8% difference. And for us, that's a huge number, especially when we are trying to avoid our patients from going in and out of the hospital to prevent viral illnesses, other germs pretty much on our NICU babies that we hold dear to us. And we also have been able to see a 60% decrease in readmissions since the start of Baby Steps in 2020.
Okay, so that was, Melody just presented our 3-year outcome, data outcomes. So we are still in the process of publishing those outcomes, but we do have some additional information here about the program from April of 2020 through December of 2022. And so these numbers are slightly different, but just to show you kind of the trends in the outcomes that we've noted with the program. So just to note, we did launch this program April of 2020, not intentional, but we got our grant funding in December of 2019, and it just happened to coincide with COVID. So in some ways that was actually really beneficial for us because, as you guys all know, people were more open to using telehealth. They were more open to avoiding the physical healthcare facility if at all possible. So you can see that this is a representation of our 30-day readmission rate. So within 30 days of leaving our NICU, whether or not a baby was readmitted, and we look at all-cause readmissions. And we started with our baseline in 2019 of 1.7% of our babies would come back within those 30 days. And then we implemented in April of 2020. And after we implemented, you can see that our rates of 30-day readmission continue to decrease. So in 2022 through December of 2022, we are at 0.41% of the babies who are enrolled in our Baby Steps program coming back. We do, as a program, we have a very low readmission rate from baseline. That was one of our concerns going in, is would we really be able to see any change? But we actually did see a change, even though we were already, you know, by our own internal metrics, we thought we were doing pretty well. The next figure here is just looking at our 30-day emergency department or urgent care center use within 30 days of discharge. So again, like Melody described, once these babies go home in that acute transition period of the first 2 weeks, there may be questions about equipment. There may be questions about a rash or feeding or a sniffle, whatever it is. And what we found in our NICU was that if the families didn't have a really good person that they could talk to very quickly to kind of assess and address this, they would go to the ED or they would go to urgent care because they are already very concerned about their baby's health. They may have been in the NICU for an extended period of time. And so they have that heightened level of concern. And so when we looked at this 30-day utilization of ED or UCC, what we were trying to see was by having the Baby Steps program and by having the direct connection with Melody, being able to access those services on demand, knowing that they had a NICU person that could help advise them, would we be able to see changes in that healthcare reutilization? And you can see in blue, we have the rates of utilization for our babies enrolled in Baby Steps. And in orange, we have the rates of reutilization for the babies who were admitted to the NICU in the same time period, but did not opt into the program. So just as a reminder, this Baby Steps program was offered to all of our infants and families in the NICU. And the only real inclusion criteria was that they had to be discharged to a home in the state of Florida. So we did not stratify by diagnosis. We didn't stratify by insurance, by gestational age. It really was open to any of our families that felt that it could be of benefit to them. The reason we don't offer it outside of the state of Florida is because of telehealth legalities and rules. We can't provide care across state lines. And for our patients that go back to a home in, you know, South America or the Caribbean, we weren't able to offer it to them either. But what you can see is consistently across the 3 years of the program, we've seen significantly decreased rates of reutilization of healthcare within 30 days for our babies who are enrolled in the Baby Steps program. And so we have it broken down by year in this figure, but you can see in 2022, 8% of our babies in Baby Steps utilized healthcare services within 30 days, compared to around 19% of those babies not enrolled in the program. This slide is a little bit busy, but we just wanted to show you some of the questions we asked in the post-encounter survey. And so we had some questions that were very much related to how accessible the telehealth platform was, how much they liked using it. And then we had some about, you know, whether or not the caregivers would be willing to use Melody's advice and act on it. And then we used questions from a validated survey that looks at parental self-efficacy. And so you can see some of those questions. I believe I have control over my baby. I can read my baby's cue. I know when my baby is sick. Those are those questions. I'm good at feeding my baby. And the reason that we wanted to look at those things is because we know that this is a really big transition for our families when they leave the NICU and they're responsible for the well-being of their infant. And so we wanted to see if by having Melody be able to give this anticipatory guidance, answer questions, really kind of be a support if we could see any change in those outcome metrics. This is data from the first year and a half of the program. We have this published, and so I just wanted to share the numbers. The percentages have really not changed much at all, but you can see that we did have the majority of our patients who self-identified as Hispanic, and also the majority of the patients enrolled in Baby Steps who use public health insurance. Those things are both important because when we think about social determinants of health, we know that historically with telehealth, those who are non-English speakers, who are not technologically literate, and who don't have access to these services tend to not use them, right? That's kind of a no-brainer. And so one of the things we really wanted to ensure, because we knew that this might be a challenge for our population, was that we very clearly explained how to use the telehealth services. And we also made sure that our caregivers had access to a device, a smart device that would make it possible. And so we actually wrote into our grant money to be able to provide a tablet to families who didn't have access to a smart device or, a cell phone. And in the whole 3 years of the program, we actually have not had a single family who has opted to take the tablet. So what we found when we did some more digging into our data and our access data is we found over 90% of our families actually access the telehealth services through a cell phone. And so I think, in our South Florida population, what we're finding is that most people themselves either have a cell phone or their family has a cell phone they can use. And so that really made it more accessible to our families, which we were very happy about because that was a major concern for us. Very quickly, just some staffing and resource requirements to think about. And, as you might think about how do you implement this sort of program, it was very important to us that we had a dedicated lead for this. And so Melody is hired into a 0.5 FTE, and Baby Steps is her entire role. We found that this is key because when you are relying on different nurses to kind of come out of staffing or kind of pitch in to do this work, often it kind of falls through the cracks. We also have 8 PRN nurses who have been trained in the telehealth and the intervention that can step in. They are, if they step into Baby Steps, we pay them like an hourly rate for their work, but otherwise they're just in general staffing in the NICU. We've also been really, we've really benefited from having our telehealth team be involved, as well as having our research leads be involved. Some things to think about from the hospital or the financial perspective, access to a telehealth platform. So historically, we've had a proprietary platform. We recently switched to, it's essentially like Zoom, right, Melody? It's branded Zoom. So, you don't necessarily need to have your own telehealth platform, but it is helpful to have some familiarity with it. Very important to either have a staff member who can speak the language of the patients or an interpreter service available. And really important to have stakeholder buy-in as well, because this could potentially impact, the follow-up of the medical team, or, if you have hospital-wide discharge coordinators, it could impact their work as well. These are just some more things to think about as, you think about if this is something that you'd like to implement. Very important in our instance that we are able to have someone who, like I said, is the lead for this, and that we have scheduled time with the families, because we know once they go home, it can be very chaotic for them and very hectic. So making sure that we establish that relationship prior to discharge, if at all possible, has been very, very important. We don't currently charge for these services because it has been grant funded, but that would be one thing to think about is, are these billable services? And if so, could that be used to offset the cost of, the 0.5 FTE nurse, perhaps, to be able to do the work? And then we've been able to demonstrate a significant potential for cost savings. So across the 3 years, between averted readmissions, averted UCC and emergency department use, travel time for the families, costs related to missed work, and all of those kind of factors, we've been able to demonstrate around $1 million that have been saved through this program. So really, when you think about the cost benefit, that's of course very important to look at as well. We have been able to publish a lot of this work. So in our collaboration with we actually train undergraduate nursing students on how to administer telehealth interventions, and we do a simulation specific to NICU babies. So if you want to read more about that, this is the citation. We're happy to send you the article as well. We published the first year and a half of the baby steps data. You can see that article here, and we're working on our 3-year data, which we're hoping will be out by the end of the year. And we actually were able to recently publish a book chapter as well. And this is more of a how to set up these sort of programs with kind of a step-by-step algorithm of implementation and what to think about. So again, we'd be happy to share this if that's of interest. We have had, I think, surprising for me, so much positive feedback and so much interest in this program.
Yeah, social media.
Yeah, and I think that a big part of it is because, you know, almost everyone either knows someone who has been in the NICU, has been in the NICU, has an infant or a grandchild who's been in the NICU, 1 out of every 10 babies. So it really does kind of touch a lot of different people. And I think also the simplicity of the program, you know, it's not anything that's very complicated, but it's this acute time period where I think a lot of people who have gone through a NICU admission, they understand that that first couple of weeks can be so difficult. And as providers, we can see that we do the best we can to support and prepare our families for discharge. But, you know, even so, when we send them home, that is a shock, right? That is a very big change for them. And so we've been able to, you know, we've had a couple of articles published in the Miami Herald. We've had LinkedIn articles. We've been recognized with a couple of different grants. We've been featured on podcasts. So really a lot of interest in the program. So moving forward, what we would like to see is we would really love to standardize this intervention. And so currently we've implemented it. We've trialed it, we've collected data in one health system, but we'd really like to work on scale and spread because we have seen such a positive impact and we want to be able to replicate that and share it. And so I think the next step is, you know, looking for birth facilities or other NICUs who'd be willing to partner and you know, be willing to try this intervention. And we are in the process of also applying for NIH funding to do some more research intensive work. We also are in the process of launching a qualitative study with our caregivers who have accessed the service to see what their experience was and how they would maybe recommend improving the program in the future or what things about the program really made a difference for them. And then one thing that Melody has found in her telehealth visits with families is that the maternal mental health piece is a huge factor in the transition to home. So of course, we know that the health of the mother is related to the health of the baby, but we found that there is this gap for maternal mental health. We personally don't do any standardized screening of our moms. And so we would love to see the ability to kind of act on that as well. So we're already reaching out to the caregivers once they're at home. Is there a way to screen and then have early referral if possible, if there is an identified need? These are just some of our publications and posters, and this is our contact information for follow-up. Thank you.
Thank you, Dr. Hernandez. Why don't we open the floor with questions? Give you all the first chance instead of me. Sarah, oh, you're clapping, okay. My question was, Melody, when you were presenting, your number of encounters didn't seem that much larger than your actual number of patients in the slides you presented. So on average, how many encounters once they leave the hospital do you have by telehealth visits?
So we register the patients. As I said, I go to their bedside, explain the process, and we count those as registered patients, even though some of those we might not have encounters with post-discharge. We have the sense that they have pretty much like a security blanket that if they needed to reach out to someone, if they needed some sort of resource, they have it. Unlike other parents that go home that don't know anything and they don't know where to call, who to call, any of those things. So then the other patients that we have seen, we do have some that have had 2 calls, 1 call. Some have had more than even 3. So it just varies on the patient and their need.
So what percentage of patients do actually end up calling you then after discharge?
It's about like our single patients, I think we're at about 400, over 400 individual patients that we've had interactions with post-discharge.
Thank you.
You're welcome.
Yeah, the majority of our families, I think, have that initial telehealth call. And then that is, for the majority of them, they have the one call. However, for those caregivers who have challenges, or maybe the baby has some technology they're not familiar with, I mean, there are families that Melody has 5 or 6, right? Like, that's where we see that those would probably be the families that were at the UCC or at the emergency room, because they really do need that support and reassurance.
Yeah, it gives a viable alternative without having to go to the ER or someplace else.
Exactly.
Sue.
I have a question. Because you're a non-birthing hospital, do you find it easier for you to track your patients in terms of returning to the ER because they're more familiar with you, as opposed to, say, a birthing hospital who had their patients sent in and then sent back and tracking that data? I'm just curious because, we have a wide variety. So that's what I'm looking at.
Yeah, that's an interesting point that I actually previously haven't thought a lot about. But I guess what I hear you saying is, if you're a birthing hospital and, that means you have adults, you might not be a PED specific hospital. If after the discharge from the NICU, maybe they want to go to, a PEDS hospital, so they go somewhere else. I think that would be a consideration.
Okay.
And one way I could think of, how could we capture that data and not lose it, is having some way to follow up with families. Have you gone to an emergency room, or have you gone to an urgent care within the last month? And was it within our system or outside? But yeah, I can see that being more challenging if you're not a children's health system. Mm-hmm.
Now, do I remember right though, Melody, you did say that many of your patients are actually not living nearby to Nicklaus. So Nicklaus is a long distance trip, if I remember right.
Yes, so a lot of our patients are transferred in as we said, as non-birthing hospital. So we have a lot of patients from the general area of Miami, but in Miami there's other institutions that are level 4 NICUs. So not necessarily are they going to always come to us unless there's some further questions, and which only our specialists are going to be able to attend to them. But from outside of our general area of Miami-Dade, we have the most specialists, and we're also on US report. We're under the US News and Report for most of our, I think we have the most pediatric specialties that are actually on that list. And so we got a lot of patients from the Keys, because in the Keys, there's only a couple pediatricians, and all the birthings that happen, if it's even like a general patient that needs a little bit of more than a nursery care, then they would be transferred to us in our NICU. And then we also see a lot of patients out of like Tampa, Orlando, Immokalee, like the more migrant area. So in those locations, we get a lot of patients from those locations also, because of the lack there of certain pediatric specialties.
Thank you. Other questions, guys? Well, Stephanie and Dr. Rubio.
Hey, yeah, so wonderful presentation. Thank you. I am curious about the NICU post-discharge survey. I don't know if you can give us a little more details on how it was put together, how it's distributed to patients, how long after the discharge, and their response rate.
So Danielle can talk about how they made the actual survey, but I'll talk about after our encounter on the telehealth platform. It's pretty much automatic. So I'll tell the patients, oh, you're going to receive a telehealth survey. Please do me the favor and fill it out. And we've had super high a rate of actually them filling it out. And I guess it's because I prompted. We had a time frame in which we weren't using our platform due to they were doing some beta testing. In that time frame, we didn't have the telehealth surveys, but now we're up and started again on our telehealth surveys. So I just tell the parents, you're going to receive this survey. It's directly after our first call They receive it after the other ones, but I tell them they only have to fill out for the first call, since that's our initial interaction. And that's pretty much where we gauge the patients that have done it, whatever were our needs. In our biweekly calls, we'll go over whatever rates were lower than expected, and I'll try and alter my consultation to those needs.
Yes, in the original survey, so we have a couple of questions that our telehealth team, they're kind of the general questions, how was your connection? Was it easy to use? Would you use telehealth again? And then we have a subset of questions that came from a validated self-efficacy, parenting self-efficacy scale. And those are the ones about, I feel confident that I can read my baby's cues. I can tell when my baby is sick. I understand how to, take care of my baby, those questions. And then they come up basically, and it looks like as soon as the telehealth window closes, it kind of pops up. So they don't need to navigate to something else. They don't need to click on a link. And I think that has really helped us with survey completion rate.
Thank you.
Any other questions?
I just wanted to add something. Hi, I'm Flortena. I'm part of this team, joined a little late. I just wanted to add that as far as the NICU, right, and our team and NICU team, we also have learned a lot from the feedback from these meetings from the Baby Steps team, because it has helped us identify the things that we needed to, really do a little bit more education or preparedness prior to discharging these families. One example that I could think of is like, when we started doing these calls, we noticed that a lot of them had so many questions about like back to sleep and putting them in, having a safe environment for the family. So we really ramped up our education in our unit regarding, the transition of care, like how fast are we getting them ready? Are we waiting until the last minute to like put them on their backs to sleep? And are we teaching enough at the bedside? So that was a great, something that came from this. And it's just one of the examples.
Thank you. The last question is, how do you plan to sustain this when grant funding is over? Because it does not sound like something that you can easily do without funding.
So it actually, when you look at the cost of it, we have a 0.5 FTE that is our only like kind of sustained cost. I have, 0.2 on it through the grant, but when the grant ends, because I'm within the health system, I can continue to do the work, but not necessarily need the time buyout. And of course, our telehealth team, most of their work was on the front end to build the system and make sure we were up and running and do troubleshooting. So we have been able to, because we demonstrated that we had over $1 million of cost savings with the program, we've been able to advocate at the system level to actually have the funding be part of our operational budget for the future. And so that's how we are going to sustain the 0.5 FTE. And then with the grant funding, we continue to try to, apply for other grants to help support this work, because there's always ways we can expand. Like I said, we could do some maternal health work. But I think the value has really kind of proven itself and over the course of the 3 years.
Thank you, and thank you. Best wishes, and we look forward to hearing more about what you all are doing. Many of the things that you do, we're trying to replicate, but in a less deluxe fashion. So thank you for taking the time to join us today.
Thank you for having us.
Thank you.
Thank you.
Thank you.